I get to talk about post-transplant treatment in the pre-transplant setting, about how difficult it is. Everyone was confused. Almost no one put their hand up to treat or not treat when that question was asked. Post-transplant, there are only 4 things that prevent us being maestros of hepatitis C. The first, of course, is viral resistance to drugs. At baseline, maybe 5, 10, 15, 20%, depending on the drug and the genotype of the virus, will have resistance-associated variants, or RAVs. Following treatment, at the time of relapse, that number is 90%. So the huge majority of virological relapse is RAV-related with currently available agents. That's going to come in the following couple of talks. I'm going to focus on the other 3 things that stand between us and mastery of hepatitis C following transplant, and that's renal disease, which is ubiquitous following liver transplantation. Patients go into transplant, they have all the things that liver disease does. You have IgA nephropathy, you have membranoproliferative glomerular nephropathy, the transplant process, calcineurin inhibitors, etc. Ribavirin is frustratingly helpful in patients with difficult-to-treat disease, including immunosuppressed patients. And then, of course, drug-drug interactions. Up to this point today, we haven't really had to hear much about drug-drug interactions, but they're important. These are my disclosures. And in terms of off-label prescribing, almost everything that I talk about today will potentially be off-label. Now, I'm going to start with a case. And I didn't know about Didier's presentation earlier. None of us saw the other slides. This was a 51-year-old nurse of ours who had hepatitis C. She also had very aggressive hepatopulmonary syndrome, was severely hypoxic. And we had an organ offer from Los Angeles from a patient who had hepatitis C, as our nurse also had hepatitis C. And the read on the local biopsy was nothing more than stage 2. So our surgeon, Di Alonso, called me and says, I got this organ offer. It's, I think, 48-year-old donor with not more than stage 2 fibrosis. What do you think? And I thought, it sounds fantastic. Let's take it. So we did. And I don't think in the history of Los Angeles a good donor organ has come out of that city. And this was not likely to be the first, but I thought it possible. She was a nurse. She was very sophisticated in providing informed consent to us. So we transplanted her. She already had jaundice and ascites before we transplanted her. She never improved her cholestasis. From the beginning, she had ascites, encephalopathy post-transplant. And then we got a biopsy very soon after transplant to see what was going on. This was H&E, where you can see the fairly aggressive portal hepatitis, some balloon degeneration, and even some lobular hepatitis 2. And the trichrome was very interesting. Remember, this was read as not more than stage 2 by the local pathologist using a frozen. And she had early cirrhosis at the time. So this was an important issue. We actually did hepatic venography, and she had portal hypertension at the beginning of this as well. So eventually, we started sofosbuvir with ledipasvir and a low dose of ribavirin, as all recipients are. She was anemic, had a bit of renal insufficiency. After starting treatment, not long afterwards, her creatinine increased to 1.79. She was a very thinly muscled woman, became almost anuric. She didn't produce more than 200 mils of urine per day. Numbers bumped up. We had decreased ribavirin, as I mentioned, and her biopsy showed acute cellular rejection that was mild to moderate. We added back in the tacrolimus that we'd subtracted out. We added Cellcept or mycophenolate as well. Because of that, we had to start a good dose of pantoprazole as well. It's worth remembering that in the mycophenolate phase 2 and phase 3 studies, there were deaths from esophageal perforation, esophageal bleeding. It's an important agent for gastrointestinal inflammation and ulceration. So we put her on pantoprazole. Her numbers actually got better. She normalized the numbers that I'll show you, and she was discharged from hospital in November, having been admitted more than 2 months before with undetectable viral RNA. These are all of her labs during treatment and afterwards. Her treatment was stopped in here. And then at 12 weeks, following 12 weeks of therapy, it was stopped. 6 weeks post-endotherapy, ALT bumped again, and she had relapsed. So what had happened? All of the things that could go wrong, I think, went wrong with this case. And I think it's illustrative for some of the difficulties with treating hep C following liver transplantation. Well, let's start with renal disease. So sofosbuvir, of course, 80% of it is excreted in the urine, most of it as the 007 metabolite. It has a half-life of 27 hours. If you look at the area under the curve for sofosbuvir, not a big effect even with severe renal dysfunction, but for the metabolite, a 450% increase. For patients on hemodialysis, a 12 to 20-fold increase. And no one knows, because the studies have not been done, what the impact in terms of safety is on a 12 to 20-fold increase of the metabolite. There are ongoing studies with sofosbuvir in patients on hemodialysis. It's partially complete. Ledipasvir, no problem. It's primarily excreted in the feces. And the same is true for all of the NS5A inhibitors. They're primarily excreted in the feces, with only 2% or less renal excretion. The 3D regimen, really no concerns here. Less than 2% of any of them are excreted in the urine. The changes that do occur with the area under the curve are not clinically significant. These are what the package or the FDA label says for each of the drugs that we're probably going to consider using. For sofosbuvir, no dose adjustment in mild to moderate disease. No dose recommendation given for eGFR or estimated GFR less than 30 mils per minute. I mentioned that the metabolite increases up to 20-fold. The active part of the drug, of course, the triphosphate, we don't know what happens to that because it doesn't make it into serum following hepatic metabolism. The recommendations for ledipasvir with sofosbuvir are the same as for SOF-SIM, no dose change needed. For 3D, of course, it's just the ribavirin that we worry about. Ribavirin, the adjustment should be 400 and 200 milligrams on alternating days for patients with GFRs between 30 to 50. People on hemodialysis are less than 30 mils, 200 milligrams once a day. We follow ribavirin levels and try and increase them as tolerated. Ribavirin and elbasvir, no dose adjustment necessary for mild, moderate, or for severe renal impairment. This looks at SOF and 007 metabolite data for patients with normal renal function versus severe renal impairment. And you can see that more than doubling of SOF levels, and for the metabolite, it's that 10 to 20-fold increase, the effects of which are not known. This is a group from Pittsburgh who looked at all of the published data, whether it's in abstract form or in paper form, for using SOF-based treatments in patients with renal failure. So far, published EPUB ahead of print in Liver International. And I'm not sure if this projects to the back, but if you compare to people with normal renal function, the frequency of severe adverse events and perhaps paradoxically of renal impairment, which is clinically relevant, doubles in patients with a GFR of less than 30 if you start treatment in this group. Efficacy, the numbers are too small. There's nothing really randomized or controlled or even prospective about these data, but they seem to be satisfactory. And there are groups who could care less about the label. So we have groups in Texas and Miami who do what they want, when they want. And they have 16 patients in Miami, 11 in Texas. There were, a lot of them were cirrhotic, 58% in the Miami group had cirrhosis at the time. And they used mostly SOF with cimeprevir without ribavirin. In the Texas group, SOF with cimeprevir, also no ribavirin. All of them achieved an SVR rate of over 80%. So it seemed like you can get away with it. But again, these are selected, non-prospective data. I think we still don't know what to make of sofosbuvir-based therapy in people with end-stage renal disease. 3D with ribavirin in treatment-naive patients with end-stage renal disease. 20 patients here presented by Paul Pokros at the last EASL. And he reported that of these patients who were genotype 1B, 10 of those, and 10 with 1A, all of them had an SVR 4. And this was with ribavirin at initiation. But 8 out of 13 with 1A had a dose reduction in ribavirin. Ribavirin and elbasvir, very attractive choice for people with renal failure, a fairly large prospective study. But in patients with relatively early stage disease, You see the 94% SVR12. This was a randomized placebo-controlled study. People were randomized, 113 of them, I think it was, to placebo initially, eventually crossing over to Recipients with Elbasvir. So this is a nice choice for patients who have renal insufficiency. 81%, the great majority, had CKD5, so dialysis quality, and you could be listed for renal transplantation with CKD5. Ribavirin. So Ribavirin, I think for years we've hoped this would go away with the more potent direct-acting antivirals. This looks at Recipients and Elbasvir with and without Ribavirin in patients with genotype 1A. If you have no resistant associated variants, almost everyone will clear virus with genotype 1A. If you do have RAVs, it's 70% versus 100%. The primary RAVs we worry about are Y93 and Q30. So the label says do RAV testing at baseline. If you have presence of RAVs, extend for 16 weeks. So add Ribavirin and give 16 weeks of therapy versus 12 weeks and no Ribavirin if you don't have RAVs. So Ribavirin is important in this context. If you use baseline RAV testing, and if you have 100 people that you screen, about 12 of them will move into the 16-week with Ribavirin group. So it's not a huge number of patients, but it's notable. For the Dipasphere, if you look at patients with cirrhosis, the Dipasphere with Sofosbuvir for 12 weeks versus Dipasphere with Sofosbuvir with Ribavirin for 12 weeks, very comparable, so everyone responds to therapy if you don't have so if you do have cirrhosis and you're treatment naive. But if you look at treatment experienced patients, the Ribavirin with and without doesn't seem to make a huge amount of difference. 24 weeks of SOF with the Dipasphere was not superior to the Dipasphere with Sofosbuvir with Ribavirin for 12 weeks. There are going to be data presented at EASL. We looked at the whole of the SOLAR studies to see what the impact of resistance-associated variants are in this population. But essentially, no cirrhosis with no RAVs. There's almost no relapse with Sofosbuvir, the Dipasphere, and Ribavirin. The significance of RAVs in the hardest group, which is treatment-experienced patients with cirrhosis, is unclear with this group. There's nothing in the label to suggest we need to look for RAVs in patients who are receiving Sofosbuvir and the Dipasphere. Valpatisvir will possibly be with us in the next few months. This is a second-generation NS5A inhibitor, and this is looking at genotype 1 patients which are sick. So these are Child's B and C patients. This is probably the high watermark. None of the protease inhibitor-based regimens will be studied in patients with CPT or Child's Pew B or C. This is probably the last decompensated study with direct-acting antiviral agents. And the patients who got Ribavirin for 12 weeks did better than patients in either the 12 or 24 with SOF and Valpatisvir. So Ribavirin will hang around in decomps with using SOF and Valpatisvir. For genotype 3, the effect was more pronounced, 85%, which was higher than any previously reported, versus 50% in either 12 or 24. So Ribavirin is still important, and our patient was not able to sustain Ribavirin dosing, and she was a 1A. So renal failure and Ribavirin is a conundrum because we have Sofosbuvir is not recommended on the label for patients with an estimated GFR less than or equal to 30, and yet Recipients and Elbasvir is not recommended in the post-transplant setting. There aren't data for Recipients and Elbasvir. Part of the concern is drug-drug interactions, so I'm going to come to in just a moment. So I would say if the patient has eGFR greater than 30, your choice is obviously a Sofosbuvir-based regimen. Renally dose Ribavirin, as we mentioned, if it's 30 to 50 mLs per minute, 200 milligrams and 400 milligrams on alternating days. If the GFR is less than 30, it's 200 milligrams per day. What you do if a patient has less than 30 for an estimated GFR, do you use a SOF-based regimen, Recipients, or the 3D regimen? You're sort of against recommendation and label whatever you do, so you really pick your against the label treatment option. Finally, drug-drug interactions. We don't have to worry too much about these in the non-transplant setting for the most part, but in the transplant setting, it's critically important. It's hard to suspend or change drugs. We think of ritonavir, of course, as being the bête noire of drug-drug interactions because of its potent inhibition of cytochrome P450, 7A1. But in addition, the ability for the direct-acting agents to get into the hepatocyte through OAT1 and to get out of the hepatocyte, most commonly through PGP, are also important. This looks at the impact of tacrolimus and cyclosporin on direct-acting antiviral levels themselves. So cyclosporin doesn't really do anything to anything other than cimeprevir. It also has been studied in healthy individuals with grisoprevir as well, and you see the same effect. So there's a concern about hepatotoxicity and high levels of grisoprevir in liver transplant recipients receiving cyclosporin. AASOD does not recommend cyclosporin and grisoprevir be administered together. Tacrolimus does not seem to be an issue. What about the direct-acting antivirals as culprits, where they alter the level of our immunosuppressive agents? For ribavirin, the dipisphere, sofosbuvir, cimeprevir, all the other drugs we've talked about, not really an issue. The only one that's important is the ritonavir component of the 3D regimen. And this causes a 5,600-fold increase percent increase in tacrolimus area under the curve. Obviously, potentially catastrophic. It can be managed, but because of the potential for this, we don't recommend it as a choice for liver transplant recipients. And it can also affect sirolimus, everolimus, and mycophenolate levels in a potentially clinically important way. So I think ritonavir should probably not be used in this setting. I know that there are centers at UCSF and probably Pittsburgh where you treated co-infected patients with ritonavir, and you can do it. But I think you need a lot of experience with it to do it well. These are some of the drugs that interact with ritonavir in terms of having their clearance altered. They include antifungals, antihypertensive, dyslipidemic agents. So this is part of the reason why I think it's probably ill-advised to do this. Our patient, we had to start mycophenolate, so we started pantoprazole. A single dose of 40 milligrams of pantoprazole can reduce sofosbuvir bioavailability by 50%. These are data looking at famotidine at 40 milligrams twice a day, and you see about a 10% change in the dipisphere area under the curve, I beg your pardon, for Cmax, and about a 10% decrease in area under the curve. If you stagger the dose, so you give the famotidine about 12 hours after dosing of sofosbuvir with the dipisphere, you lose most of that decrease. With the omeprazole, just 20 milligram dosing, you have about a 10% decrease, 11% decrease in the dipisphere exposure. So for this reason, we recommend not using proton pump if you can avoid it. If you can switch them to an H2 receptor antagonist, better. But some people have to be on the PPIs, like liver transplant recipients. So what to do in that setting? It's actually not hard to manage. The ideal gastric pH for the dipisphere, and the same is true for valpatisvir as well, is a gastric pH of around 2. And if somebody's not on a PPI or an H2RI, this is about what you will achieve. If you have a standard dose PPI, so 40 milligrams a day of omeprazole, this is the 24-hour gastric pH change, and 40 milligrams twice a day on the higher curve here. This is the pH, gastric pH of fruit juices, and two of them stood out. If you look at cranberries and lemon and lime juice, which is not diluted or sugared, you have a gastric pH of 2. So we get our patients essentially drink cranberry juice at the same time. Remember, for PPIs, the dosing should be given simultaneously, and then we give cranberry juice as well. We haven't had another treatment failure since adopting this protocol. Gastric production falls by 96%. Gastric acid production falls by 96% on 60 milligrams a day of omeprazole. It's an important drug-drug interaction, and it takes between 3 and 5 days for the proton pumps to regenerate. So for the PPIs and acid suppression, stop them, transfer to an H2 receptor antagonist when possible. If it's somebody who's further out from transplant, often the MMF is stopped, and they often don't have an ongoing reason to be on a proton pump inhibitor. So look to see if it's possible to stop it. There's frequently no history of GERD in these patients. And switching to 20 milligrams a day of omeprazole is fine. You don't have to worry about it if you're just using 20 milligrams a day of omeprazole. So what happened with our patient? Well, she had rejection. That meant she had to have MMF, which meant that she had to have a proton pump inhibitor, so she probably got less sofosbuvir exposure than she wanted. She had ribavirin dosing that was incomplete, and For, I think, all these combination of reasons, in addition to a renal insufficiency, which led to ribavirin dosing, those three things lead to reduction in efficacy. So on that note, I'm going to conclude, and I thank you very much for your attention.